So this is a troubleshooting session, and the idea is that central venous catheter insertion, it's a simple procedure. It's about as simple as we'll get in healthcare, but like anything in healthcare, it can go wrong. And part of the training is that we've given you this map through what is essentially a minefield. There are a lot of ways that this procedure can go wrong. You need a map to get you through, but my bet is at some point you're probably going to step off the beaten path, understanding how it can go wrong and your recovery strategies. And so the first part is the sterile prep. So you get your sterile prep marker or your ChloraPrep. You're going to prep an area. I oftentimes chide people for prepping too small an area. I don't chide people for too big an area. So it's actually hard to prep too big an area. You definitely want to have enough room, because when you put on the drape, and I'm going to use the paper napkin as I call it, you want to make sure that it's quite easy to hit your spot, that you don't want to be moving it back and forth afterwards, because that's one of the problems that you'll contaminate your procedure. The other is if you see the paper napkin, you want to throw it out. The problem with the paper napkin is that when we get further into the procedure and you have the wire is exceeding the edge of the paper napkin, okay? And that wire will come and it will find, the halfway through your chest, your upper arm. This is what maximum sterile barriers really buy you, is enough room so that you don't have to worry about this wire coming and hitting something. That's why you wear a sterile gown. That's why you cover your chest, and that's why we have the bigger drape. So if you find the paper napkin, your job is really to wad it up and throw it away. And when you're doing your prep, it takes the manufacturer would say, minute, okay, for the alcohol within the prep stick to dry. And so when you prep, you don't want to be putting your drape right on top of that, because it's wet, the drape won't stick. That's the time that after you've prepped, that you spend some time getting everything else ready, putting on your gown and gloves, and using that time to do something constructive while you're waiting for this to dry and actually become a sterile field. So again, this is the white paper napkin drape. If you see it, you want to wad it up and throw it away. I'm just going to use it for a demonstration. It's sort of interesting to think, why the small drape? And the answer is that, what do you think one of these costs? I can tell you the entire kit costs about $25 to $30, which means inside this kit, this drape is probably on the order of 25 cents to 50 cents. So this is the quarter drape. The big drape that you actually are supposed to use during the procedure, it might cost $1, okay? And when we're showing how the wire sticks out, and if you're not wearing the gown, so the gown costs $1, the gloves cost $1, all these things to prevent a central line infection might add up to $5. The cost of a central line infection, I like asking this question to get sort of a ballpark as to what people think it is. It's about $40,000, okay? And so if you contaminate your gloves, if you contaminate your gown, if you drop the big blue drape and you think, I'll just use the paper napkin this time, you're basically saving a couple bucks for the risk of $40,000. Not a very good bet in any financial market. So again, if you need to use more supplies, the patients will thank you. Gaining access. When you stick the needle in, the good news would be that you get a blood return, you've hit the vein. The bad news is that you can hit something else. And honestly, the structure that you can hit is the nearby artery. And so the question becomes, how are you going to recognize that you've punctured the vein and not the artery? Because if you do this procedure 5 times, yeah, you might hit the vein 5 times in a row. But if you do it 100 times, my bet is at some point you will stick the artery, and the big thing is recognizing that you've stuck the artery. And the clues are, it spurts blood, okay? It's under high pressure. The other is that the blood typically is a brighter red than venous blood. And the third clue is if you're using ultrasound or some sort of other form of guidance, you'll actually see where the needle tip is, and hopefully you've gotten to the right structure. So the key that you have to ask yourself is, after you stuck the needle in and you're getting blood back, is this a possibility that I've actually stuck the artery? And again, you're going to use your cues. The problem, though, is that you'll be in situations where you don't have the cues. If the patient's coding has no blood pressure, all their blood's blue, and even if you're using guidance, you can still stick the artery and not know it. And so in those cases, really what we said, if this is a flat-out code, in many cases it's better to go stick the groin, because if you get the artery in the groin, it's regrettable, okay? But it's not catastrophic. If you stick the artery, if you put your catheter with the dilator and with the catheter eventually, and you leave it in the carotid artery, that is a catastrophe. You can actually severely injure patients sticking their carotid artery and not recognizing it. So again, you're going to use 3 cues to try and recognize what vessel you stuck, and if it is the time that you stick the carotid artery, hopefully you'll recognize it. Everybody puts their finger over it, okay, because it's already spurting blood. But it's, what do you do? Some people would say, well, I want to call somebody else for help. Really, it is the time that you need to scratch your head and say, I checked the coags before I did this procedure, and they're okay, and therefore I can remove the needle, hold pressure, and again, it's regrettable that you stuck the carotid artery with an 18-gauge needle, but it's not a catastrophe. Pulling out and holding pressure is a perfectly good recovery strategy. Next step is, you've gotten access, you convince yourself that it's venous, and you want to thread your guide wire in. And I know we've practiced the guide wire techniques, and again, this is what you want that big drape for, so that you have plenty of room up here to work with. You're going to guide your guide wire down to about 20 centimeters. 20 centimeters is the goal, and I'm sticking my needle back in my sharps container because that's where it's supposed to live. But once I get to 20 centimeters, and I can see that because there's a mark with 2 hashes on the guide wire, once I get to 20 centimeters, I'm done. I don't need to stick it in any further. There are some, and I actually grew up in the school where we had the paper napkin, and so we had a pretty small drape, and we pretty routinely stuck our guide wires in much further. The problem with that is that that's when you go down and you snag, say, the IVC filter down below the diaphragm, or you've wadded this up inside the patient's ventricle and they're going into VTAC, okay? So 20 centimeters avoids the problems of going in too far. Now, some would say, well, geez, I'm really worried this patient has an IVC filter. I'm going to leave it, 15, no, I'm going to leave it really short, okay? I've got my big drape, I'm going to leave it really short. The problem that occurs is that when you put on your next step, which is a dilator, is that for some reason everybody wants to shove in the dilator as far as it goes, okay? This is probably a 25-cent item, but we want to get our money's worth out of it, and so we shove it in as far as we go, and if we exceed the tip of the guide wire, and I can pass this around and people can do this, this becomes a sharp object. I mean, this is a weapon. With the guide wire sticking out the tip, I mean, I really can't injure anybody, but if I have, without the guide wire, this is how you rip through somebody's vessel. So again, the idea is that if you go to 20 centimeters with your guide wire, you can take this, and really you only have to go to 5 centimeters with the dilator. You're just trying to dilate the tract down to the vein so that you can then get your catheter in. And as I'm going through these different steps, I'm just checking to see that my 20 centimeter mark is still at the skin. And then I've threaded on my catheter. And again, it feels sort of weird to have this much wire sticking out, but again, that's why you want a big sterile field up here so that you have this room to work. And it's almost by magic, and it's a design system that if I left it at 20 centimeters, the back end of the wire basically magically appears out the back end of my catheter. I slide my catheter into 15 centimeters, and 15 centimeters is the mark. I pull it out, and I'm done. So one of the big reasons we put together this course was the problem with retained guide wires, and a lot of different ideas about what was leading to retained guide wires. And I'm going to walk you through the steps if you want to leave a guide wire inside somebody. This is how you do it. The first problem that we believe is that people were routinely going past 20 centimeters. They didn't believe anything that we were telling them, and they had the short paper napkin drape up here. And so there's a crew that would routinely leave only a small amount of guide wire sticking out. Okay, so that's failure number one. That's stepping on the first mine, and it hasn't really exploded yet. The second was not recognizing that problem when they went to thread the guide wire on. And again, if you're at 20 centimeters, you know, it's like magic, okay? I'm at the 20 centimeter mark, the back end of my guide wire sticking out the brown hub. No matter what I do, if I start threading in this catheter, I won't have a catastrophe. But again, if you stepped on the first mine and keep going deeper into the minefield, you'll be at 40 centimeters, you stick the catheter on, and now you're sliding. And if you notice now when I push in the catheter, the guide wire moves back and forth, okay? If I go to 15 centimeters, I've got the guide wire in a good distance. I can still recover from this. I can still get back onto the beaten path if I recognize, oh my goodness, I don't have the back end of the guide wire. Pull back, and the guide wire's there. Okay, the third step deeper into the minefield is at the end of the procedure not recognizing that you did two things wrong. One was wire in too far. The second was not getting your wire before you flush the catheter. But now the ultimate step is when you flush the catheter, it doesn't take an incredible amount of force to propel that guide wire across the room, okay? It just honestly, to me, feels like I'm flushing the catheter. And that was what it was ejecting the guide wire from the catheter. That now it's the only way you recover from this is you'll see it on your x-ray and calling somebody to go fish out the guide wire. And you'll also spend about 30 hours in meetings explaining how you took 3 steps, one after the other, into the minefield. So 2 other problems that occur are difficulty advancing the guide wire and also having difficulty pulling it back. So the keys when you're trying to advance is recognizing how much wire you've got in before you're having difficulty advancing. So if you can't get to the 10 centimeter mark on your guide wire, the needles in these kits on the order of 5 to 7 centimeters long, and so if you can't get to 10, it's probably you're having difficulty when the wire is trying to come out the needle and get into the vein. And so one of the most common things is that your needle's no longer in the vein, okay? Rather than forcing a guide wire when your needle is no longer in the vein, it's better often, well, if you got ultrasound, you can check, but if you don't, you might as well start over, okay? You've invested, some time, but if you're not getting it in and you're not inside the vein when you're advancing a guide wire, you're going to create more trauma and more problems rather than simply starting over and getting a clean stick. This other would be is that you're past the 10 centimeter mark, but you can't get to 20, okay? So you're halfway down, you're inside the venous system, and it goes back to when you were discussing this procedure with the patient, getting set up for the procedure, having a history. If this is a dialysis patient, they've had all their catheters on one side and you're trying to stick it again on the same side, it's possible that they've got scar tissue inside a vein that's blocking, and that's why your wire won't go centrally, okay? And so it goes back to, having the right patient population to do this procedure rather than trying to do this as a bedside procedure in the most difficult patients. We definitely struggle. I've got fluoroscopy. I can see what's going on inside patients to get my wire through a narrowing or even push it through an occlusion. You can't do that at the bedside. So if you're having trouble getting to 20 centimeters, sometimes it is abandoning and going to another spot. And you start to pull your wire and for some reason it doesn't come back. One possibility is that you ignored everything that we taught you and you went down and you put your wire in so far that you've snagged the IVC filter. You'll recognize that by the fact that you have very little wire sticking out. If you look at it at 15 centimeters, the wire's at 20, there's a lot of wire sticking out. The other possibility is that you're trying to pull your wire out, is that it is possible if you're going back and forth with your wire, the wire can bend on itself. It can actually even wrap around itself and not, okay? And so when you try and pull this back through the catheter, it won't come. That occurs, extremely infrequently, less than once a year, but it is one of the possibilities. If you've unfortunately gone and snagged your IVC filter, the wrong answer is to pull back harder. Okay, the right answer is to recognize that you've stepped on the mine, it's clicked, but it hasn't entirely gone off. It's not a catastrophe yet. It'll be a catastrophe when you pull the filter into the right atrium, and that's the time to call the cavalry. That's the time to say, I've got a problem and I'm not going to be able to fix the bedside. It is possible to release the guide wire, but it takes imaging and it requires being able to see what you're doing while you're going through the steps. If you think your wire's knotted, it's also time to step back, call the cavalry, get somebody that can watch what they're doing deep underneath the skin while they're doing these procedures. A third set of problems with the guide wire coming back through the needle. So I've got a wire that has a kink, and I'm going to make it a little bit worse. And those kinks come because, you ran into the obstruction and people kept trying to force their way through it. And so you can bend the guide wire. It definitely happens. And so wire's a ways in, it's bent, you pull it, and honestly what you end up feeling is some resistance pulling out the guide wire. Okay. If it occurs within, again, the first 10 centimeters, okay, you probably bent the wire right next to the tip of the needle. If you're between 10 and 20 centimeters, you probably bent the guide wire a little bit further on. If you start pulling on the guide wire and you're getting a lot of resistance, the question, what is your next step? The wrong answer is pull harder. Because this guide wire actually can start to unravel and you're leaving half of it in the patient and it feels like you're pulling a string and it just keeps going. You are about 10 seconds away at that point from another type of catastrophe, which is the retained foreign body, where you fractured the guide wire and you're going to leave a segment inside the patient. Again, those are the times to recognize that you're in really deep. You've stepped on the landmine, it's clicked, it's about to go off, but you can still have a recovery strategy if you're willing to step back and say, this is bad, I need to call somebody for some help. If you're just pulling on it though and there's a little bit of resistance, oftentimes the best solution is to pull everything as a unit. The reason this guide wire creates resistance is you're trying to take a bent piece of metal through a straight piece of metal, and that's where you're getting the resistance. Making the skin nick. I know that there's occasionally some that will say you could damage the guide wire with the blade. Okay, if you take this blade and you actually touch the sharp edge to the guide wire, it can damage the guide wire. I'm going to take this blade and this wire and purposely I've really abused it, and running my fingers along it, I can sort of feel where I was trying to saw this guide wire in two. I challenge anybody to actually take one of these blades and use it to cut a guide wire in two. I don't think it can be done. I don't recommend it. So guide wires are tough. And so when you're making your skin nick, my opinion is that it makes sense to be right next to the guide wire, because that's the path that you need to open up for the dilator and for the catheter. Nobody is born knowing how to do this procedure, okay? We learned it because we went through training, and unfortunately some of that training really revolves around making mistakes and recovering from them. And so if you uncover a mistake, we want to hear about it so that we capture this knowledge and incorporate it into a course.